Great. So I'm going to talk about COVID-19. Where are we now? It's been 3 years. It's kind of crazy how long it's been, and what have we learned, and how this associates with MS. And here are my objectives. We're going to talk first. I'm going to take a step back and just talk about immune system basics. I think that's helpful in the context of understanding some of the data that I'm going to show you with vaccination response with various disease-modifying therapies in patients with MS and other autoimmune disease. And then I'm going to show you some data that we have here from our studies at the University of Colorado. So this picture shows, just generally speaking, our immune system. You have an innate immune system, which you're born with. This is your immune system that does not necessarily learn. It's there when you're born. It's there to fight infection. But then you have another part of the immune system called the adaptive immune system. And this is your part of immune system that grows with you as you age into adulthood. And it's a learning part of the immune system. So you have your B cells, which make antibodies. So every time you're exposed to a virus or a bacteria, whatever the infectious pathogen is, your immune system, your B cells will make these antibodies in response to that infection. And then you also have another component of the adaptive immune system called your T cells. And your T cells don't necessarily make the antibody. They have a lot of different roles. Part of it is having some memory, as well as there's ways that they can activate the B cells. But this is important as we talk about, one of the most common drugs that we use for MS is anti-CD20s, which is a drug that basically depletes those B cells. So you don't have those antibodies being produced. It does not affect those T cells. And we'll get into that when we talk about some of the response to vaccines. And so this is just a little bit of an overview slide. Again, it's been 3 years. It's crazy. It's kind of amazing how much research has been done in just a short time, like 3 years. Although on the flip side of that, sometimes it feels like an eternity since the pandemic happened. But if you go in and search in PubMed, do a quick and dirty search, typing in COVID-19 and MS, you can see you get a ton of different articles, 461 just over the course of 3 years. And this is a wide range of research that has been done in this overlap of COVID and MS, looking at, outcomes based on what drugs people are taking, how to deal with MS pregnancy and COVID infection. Again, more looking at disease-modifying therapy and vaccination response. And I can go on, and this is just some of them. So when the pandemic first hit, there were a lot of early reports on outcomes of COVID-19 in patients with MS, which were mostly reassuring. They were small studies, but there were a couple out there that did raise some concern about worse outcomes. And really, when you look at the data throughout the years, it was not so much the diagnosis of MS, maybe a little bit of what disease-modifying therapy you were on, but really not significant. It was really dependent on the other factors that we know that cause severe infection, and that was really age and coexisting medical conditions like heart disease. And so Again, I think it's kind of amazing what has happened over the 3 years. The neurologic world really quickly adapted to the pandemic, and we saw a lot of recommendations coming out with trying to figure out what to do with disease-modifying therapy in the pandemic, what to do with vaccination. And I think one of the really amazing things that came out is our use of telemedicine. And that's very integrated into our clinic today. So the pandemic had some positives. This is a very hard slide to read, but it does have a QR code if you want to. I'll take a moment here if you want to take a look on your phone. Basically, again, a lot of research has gone into, okay, if you're on whatever your disease modifying therapy is, how does that reflect your immune response to the vaccine? And there's data now in almost all DMTs as summarized here on this table. I'll wait until I see kind of phones go down. All right, cool. Here's another QR code. I like them. I was getting fancy. But this is one of our posters. So we partnered with NYU on a project sponsored by Genentech and Roche, looking at the immune system response to vaccination, both original vaccine, and then there was an arm with a booster vaccine in patients treated with ocrelizumab. And this is from our poster that was presented at one of the MS meetings, ECTRIMS, in 2022. And you can see here summarized on this slide, the study outline. We enrolled patients prior to their original series vaccine. And then there was a cohort of patients that chose to get the booster. And it just kind of worked out that it ended up being almost 50-50. So we had some nice data in those two different cohorts. And you could see summarized here on the bottom, we had 60 patients with MS that were enrolled, and the majority were female patients at 73%. We had a very nice, diverse population, which is unusual for some of the MS studies. So I think that was kind of a strength to this study and paper. And we also had data about half of the patients in this study had COVID prior to their initial vaccine series, while the other half did not. And that's important as we look through the data, because there's now data to support that you get this kind of extra boost hybrid immunity if you have a combination of having prior infection as well as the vaccine. And all the vaccines in this study were mRNA vaccines, so your Pfizer and Moderna. And so this is a picture that is a little bit complicated, but I'll do my best to summarize of that was just taken from the poster here. But it looks at these this antibody response. So this is your B cells producing antibodies against COVID infection after you get the vaccine at baseline. So before you had the vaccine. And there are some patients, like I said, about 50-50 that had infection before and after. So if you didn't have infection at any point in time recorded during the study, you stay orange as an orange dot. Otherwise, if you had infection, that's the purple dot. And we're looking at different time points out from the vaccine at 4 weeks, 12 weeks, and 24 weeks. And you can see here, and there's a little bit of a spread, but it's seen best in kind of these booster patients. I think it really comes to light where you have this cluster of patients that do produce antibodies while on ocrelizumab, and then you have this cluster of patients that really don't. And generally speaking, the antibody response is pretty blunted compared to healthy controls, which I'll show you in the next slide. But it almost breaks up where you have these responders and non-responders. And even if you had the first series of vaccine, if you were a non-responder, you kind of stayed a non-responder. So we're trying to understand of what makes you a non-responder versus responder. But it's normal to kind of see this waning of antibodies over time, even in healthy individuals. And this slide shows it a little bit better. This is from the same study, the poster presented in 2021. So we only had out to 12-week data for this particular figure. But you can see this is every line is an individual. And so if you look at healthy people in terms of not on an immune suppressing agent and should have a normal response to their immune system, you do after the vaccine see this bump in antibodies being produced at 4 weeks, but even after that, they wane at 12 weeks. So it's not surprising that even for patients, again, with a normal immune system, they might get vaccinated and they still get COVID 4 months later, because we see this dip in antibodies. And with the MS patients on ocrelizumab, again, you get this clustering of what seem to be responders versus non-responders to the vaccine. But overall, regardless, it is blunted compared to healthy controls. But all is not lost, because the T cell response was actually quite good. And impressively, for MS patients on ocrelizumab, they actually had a more robust T cell response than healthy controls. It's almost as if you had a dysfunction of those B cells not producing antibodies and the T cells were overcompensating. And this T cell response does seem to be maintained even at 24 weeks, which again is encouraging. And this is so that was our study that we partnered with NYU. We did our own observational study here, a little bit smaller scale, that was presented at the American Academy of Neurology a year ago. And we also looked at a smaller group of patients, a little bit of a mix of MS plus other autoimmune disease, but all the patients were on anti-CD20 therapies, just like ocrelizumab, although we also included some of those other ones that are similar, like rituximab. And this is our study outline. You can see the numbers are smaller, but we did collect at the time of the original vaccine as well as booster. And so this slide here kind of summarizes and confirms what has been identified in many, many studies beyond just our site here, that yes, we do see this blunted antibody response. We were a little more blunted across the board than having this dichotomy of responders and non-responders, but still kind of goes along with the same story. And again, similar to what others have found, we saw in this cohort that the T cell response was still quite robust and very, very good compared to healthy controls. And so in this graph here, you have patients in the black dots that got the vaccine. You have patients in the red dots that were diagnosed with COVID, and these were pretty severe COVID patients hospitalized. So you would have anticipated that surviving that, they should have had a very robust immune system response. And then you have patients that are anti-CD20 patients in the blue dots. And you can see here that patients, when you compare among healthy but got severe COVID and anti-CD20s, you still have that better T cell response in those anti-CD20 patients. We took it a step further here in this small group, and we looked at two different ways of measuring the T cells. So we use the research assays that most places have been using, same kind of concept and methodology. But we also looked at a T cell assay that was more commercially available and easy to do in the clinic. And this was when we partnered with Euroimmune, who produces this antibody assay. And so looking at these two assays, we were able to compare between the research assay and kind of the easy, dirty commercial assay, and we had a nice correlation. So this paper is currently under review, but this might be a nice way of measuring T cell response in the clinic, because right now our best way of measuring this is antibodies, and we know antibodies don't really help us that much. So what have we learned through all of this in the last 3 years? Well, overall, big picture is that these vaccines are recommended for all MS patients. Even though you might have a blunted antibody response, the T cell response is still very good. So what does that mean? When you have circulating antibodies, if you have an infection that comes across those antibodies, meaning you were exposed and you have antibodies circulating in the blood, the antibodies bind that virus and take care of it before it's even a problem. When you have those T cells working, the infection might come across, it might get into a cell and it starts replicating. But because of the way the T cells function, as soon as that virus starts doing its dirty job of replicating, it's a signal to those cells that those T cells fight immediately. And so what that means is while you didn't clear the infection did get in, but your body's actually fighting it. So you have more of a mild infection. So we see, and we've seen that with not just in MS, but just as a whole, for patients that are getting their vaccines or have been exposed to COVID, subsequent infections tend to be more mild, and patients are staying out of the hospital. And now we're to the point where I think we've learned a lot about what to expect with the vaccines, and now we're at the point where we're optimizing patient care on an individual level. And coordinating, when this first came out, it was get your vaccine, get it when it's available. And there wasn't really a choice in timing sometimes with your medications. And you had to make the best decision possible. But now we have more data, we have more time, and we can optimize things by planning the vaccine at certain times, depending on if you're on infusion medications. And that may help. So, like I said, a lot of research in 3 years. Where are we? We know MS alone does not seem to increase the risk of severe COVID. There are other factors at play, especially age. Men tend to do worse in many of the studies, and patients with higher disability, that matters. DMT may matter a little bit. And at this point, we're at a real personalized approach, kind of doing this risk assessment, figuring out risk, benefit, and making a shared decision making with your neurologist or physician. Thank you.